So it is my pleasure to introduce the panelists for Better Together, Health Equity Work Across the Prostate Cancer Community. We have, at the end, of course, everyone knows our moderator, Courtney Bugler. We have Dr. Charles Ryan, an internationally recognized genitourinary oncologist with expertise in the biology and treatment of advanced disease, as well as the supportive care of all men with prostate cancer. And please note, you have full bios in your program. We have Adrian Bacchus, with more than 30 years of experience in educational and religious institutions, international assistance, and industry, who currently serves as the Director of Partnership Development and Outreach for the Prostate Health Education Network, also known as PHEN. Shanta Chambers is a nonprofit executive and public health professional with more than 25 years of experience in chronic disease prevention, health promotion, community engagement, and women's health. She is the Executive Vice President for Health Equity Initiatives and Community Engagement for the Patient Advocate Foundation, who of course is the partner we work with closely on our 0360 program. Finally, we have Dr. Bill Dayhut, the Chief Scientific Officer for the American Cancer Society, responsible for the strategic direction of both intramural and extramural research for the largest nonprofit funder of cancer research. And I'm going to hand it over to Courtney.
Thanks, Allie. So we're going to be talking a little bit about how we are all working both in our organizations and across the space to decrease the disparity between that's happening in Black men in prostate cancer, especially as it relates to screening and diagnosis, which will of course lead to other outcomes. So I'm going to start, and I'll start with you, Chuck. What do you think is the most important thing that's either happening for all of you, either at your own organization or across the space that is working to decrease these disparities?
Oh, yes, so I have a mic on. Well, thank you, Courtney, and it's great to be here and to just talk about this really important issue. Now, I'm going to speak on behalf of the Prostate Cancer Foundation, which I was the CEO of until just very recently. Even prior to that, there was a fairly broad understanding that when we looked at data around screening for prostate cancer, that it was largely about the outcomes of data for screening for white men. And Black men were really a very small proportion of the individuals who participated in screening clinical trials. And that leaves a data gap. One way to address the data gap is to do research and to do screening trials and spend a lot of time sorting out how a particular population may fare in a screening population. But that's a big investment in time and money. And not that it's not worth doing, but we decided at the PCF to start by doing essentially a panel of experts, a literature review to look at what were the best practices around screening, what would be the ways that we could approach screening for prostate cancer for Black men that might be different from other individuals based on incidence and epidemiology. And so we have presented, and it will be published very, very soon, the first ever screening guidelines that specifically pertain to Black men in the United States.
Awesome.
Can you hear me? Mm-hmm. Yes. You would think a preacher would know how to use a mic.
You probably don't need a mic.
And also not have cheat notes. But I have a boss and I want to keep a job, so I better say the right thing and do the right thing. But I want to say thank you, first of all, for the invitation on behalf of our president and founder, Thomas A. Farrington, who's a 24-year survivor. I think I got that right. It's very glad that we're represented here today. We basically had started in 2003, Mr. Farrington. This is our 20th year, actually, that Finn will be here and what we do. And there are several major focus programs that we have for this year. One involves our annual summit. That's generally in September, and that's where we bring leaders across the country, patients and others like what you're doing here today to talk, discuss, and find resolutions that we might help on the issue of prostate cancer. His focus always and the mission was on the elimination of this disparity that exists within the African American community. So we've been tireless. We say we have an air game, which might be more with the virtual and all that, and then we have a ground game. They kind of put the troops out there. We have also, we work with clinical trials. That's another thing that we've done. We do roundtables, and so the focus has been in the area of clinical trials because many people have not participated in that. We go historical and trying to convince our community that it's not the same as it was way back. This is a whole different aspect, so we have a whole website and issues of what we do on clinical trials. Our other area is our prostate cancer disparity rally. We're really excited about that. We basically are doing a communications campaign rally across the country, both on radio and also in social media. And it's been very focused. I'll talk a little bit about that. We've hit about 23 cities in about 14 states. And at 5 o'clock tomorrow morning, he and I will be in Mississippi, and we have culminate with town hall meetings. And we use all the leaders and patients and local leaders, elected leaders, all of them state and federal. So we've been really active on the ground, and then we hope that in those communities they will continue to do the work to help in the area of the disparity. Church partnerships and educational outreach is a major focus of mine as well. We have had over 1,000 churches. We are stepping the game up. We are actually in the development of church portals around this country, and I'll speak a little bit about that because the black church is a critical unit within the black community in terms of health and so many other things, as you've seen with COVID, as you've seen with AIDS, major delivery system. On the issue of trust, that's another thing that I found when I was vice president of Princeton Theological Seminary for 20 years. The issue in terms of trust becomes very critical in terms of delivery systems. And the last area that we have is patient education and empowerment. We have what we call FIN ambassadors who are out on the streets working, doing barbershops, doing all kinds of things. And we have empowerment, different types of session at Dana-Farber that's actually broadcasted on the social media.
Thanks. Shanta, what about you guys at PCF, or PAF?
So, question clarification in terms of those things that we think are contributing to the disparities, or how PAF is responding to those
How
disparities?
you're responding to them.
So, I wanted the clarity because clarity is very important. So, as Ali pointed out, for some time now, PAF and Zero have had this long-lasting partnership around Zero 360. That is really represents Zero commitment to address the social drivers of health. The greatest contributing factor to disparities is the assumption that health takes place in the four walls of the healthcare system. The problem is, health takes place in the community. And if you go back and look at any community in this country, you'll see all the very drivers that are exacerbating the disparities. As you think about how we move forward, as an organization, PAF has been really looking at these non-clinical barriers to care, things such as food insecurity, housing insecurity, access and affordability. These are all factors that continue to contribute to these disparities, and PAF likes to be on the front line, along with our partner Zero, in addressing these. Because as you think about tomorrow, one thing, don't settle for the talking points, because it has been historical policies that continue to perpetuate the disparities that we see play out in healthcare access and affordability for so many individuals, like many of you that are represented in this room. So collectively, we have to challenge the current system to do things different, because just to say okay is really a passive assimilation, and we'll continue to see these disparities grow. We also have to make sure collectively that we are raising these issues around housing insecurity. It doesn't matter how great our science is if those who need it can't even safely access it in their home. We also have to make sure that the therapies, the innovations that we're bringing forth, they're available to everyone, no matter who they are or where they live. We currently have a 10% uninsured rate in the US. Right here. Yes, we made some improvements with ACA. We saw that play out and even our patient service data. But now we're starting to see those increases of those that are uninsured beginning to rise again. We have to remember health starts in the community, and it is our collective impact that is going to be necessary to turn this tide. You know, people often say a rising tide raises all boats, but let's remember that there are many that don't even have a boat to put in the water.
I don't know about you, but I'd follow Shanta pretty much anywhere. Bill, what are you all doing at ACS?
So, first of all, it's great being here. And, based on our data we published last year in Cancer Facts and Figures, what we had seen is that prostate cancer mortality fell about 50% from early 90s to around 2012. But those mortality curves now have totally flattened. And we're seeing over the last decade about a 3 to 5% increase in men presented with more advanced disease, sort of as screening levels had fallen. And so based on that, what we did, we launched our IMPACT initiative, which is improving prostate cancer mortality together. And that's why it's so great to be working here together. And we actually reflected a little bit what American Cancer Society had been doing in the prostate space, and really we hadn't been doing enough. Certainly not in the messaging and certainly not in the funding. So we are launching several new funding initiatives this year. Probably one that I think is particularly exciting we're launching an initiative to really facilitate the enrollment of particularly black men on prostate clinical trials, really focused outside the cancer centers. And we're working with some outside partners to provide increased community engagement, infrastructure at the sites, access to trials through an organization which we work through, which I think is really focused on allowing many more men on prostate cancer clinical trials. Also funding for other work in order to facilitate new investigators in the field, our work also with the historical black community colleges and universities. So we are very invested in this space. We know we need to work this together. We know community engagement is really a core of that, and just very happy to be here.
Thanks, Bill. So I'm going to stay with you for just a second. You mentioned, your facts and figures and the data that we've recently seen. Can you share with us any information that you all have that was either in that or that you guys have seen related to screening rates?
Yeah, so screening rates are interesting or depressing, depending on how you want to look at it. And this was published recently, and some of it is obviously impacted a little bit by COVID. But overall, if you looked in the past year, men between the ages of 50 and 64, sort of the core group, everybody should be screened, only 25% of all men in that age group had a PSA in the last year. 25 had a blood test. I don't know why people think you're going to fall over and become incontinent after this blood test. It must be a pretty big needle, but it's. And then if you look at groups, if you look at the uninsured, only 10% had. If you looked on racial groups, about 38% of whites, and only about 31% of blacks. The group over the age of 65, actually over the age of 65, they were a much higher percentage, about 46%. So I think folks who had early on had started screening, as their primary care doctors actually probably got older too, their screening rates still not what they should be, but better than the people that are sort of the core groups to look at it. So I think we all know if we go back 20 or 30 years, how men with prostate cancer are treated are vastly different. We know not every man needs to be treated emergently. We know radiation techniques are better, surgical techniques are better, outcomes are better. So I think this fear that this blood test is going to lead to impotence and incontinence by the end of the day and terrifying physicians to even recommend it is something we really need to work on together. And that's why I'm so glad that Chuck's talking about work that the PCF has led to actually look at this more broadly.
Right, so the PCF work actually highlighted a couple different things. One is for black men, the onset of prostate cancer is likely about a decade earlier as it is for white men. And so that means you should be looking at around age 40 as the time when this begins. And that's based on epidemiological data on when the incidence begins to rise. So that's number one. Number two is the screening rates for black men are at baseline about half of what I think they are for the general population. And so there's a lot of room to move up in that regard. And then the third thing is, I'll just echo what Bill said, which is screening is not the beginning of an automatic process that leads to removal of the prostate or radiation or even treatment. And in 2024, we are doing smart screening, and I call it risk-adapted response to screening. Where really what's most important is the conversation that begins after the screening if there looks like there is something that needs to be followed up on. And the final point is the digital rectal exam, which is a feared part of the screening, is actually kind of on its way out. And what's happening is PSA testing as a blood test as the initial foray into the process, usually followed by an MRI scan or some sort of confirmatory test that does not involve a digital rectal exam. And so a lot of times when people hear that, they think, okay, well, that's a good thing to know because that's what they fear in going to the doctor, and that's really something that is not so much part of the standard process anymore.
Yeah, but the shared decision making is so much better once you have a PSA test back.
Yeah.
Than should I get the PSA? Because the PSA value is very high. It's very different than the PSA value is very low. And so that's actually when those conversations need to occur. You know, should I go on to an MRI? Should I go on to a urologist? Or should I just come back in 3 months to repeat this? So this whole, you know, of course, if somebody doesn't want a PSA test because they never would want to receive treatment, that of course makes sense. Of course, they should know that's having it drawn. But the conversations about the nuances of getting a blood test that might say, just all that's really doing is letting you know what your risk of prostate cancer is. And based on that, that's when you can start having the conversations which actually are much more informative for everybody.
So as we talk about this, as I was seeing Adrian go, I think I have some thoughts. Obviously, a lot of that is related to shared decision-making and stigma. And obviously, FEN is so good at working in the Black community. What are some of the things that you guys see when you're there, and how are you combating some of that misinformation around screening?
I think for me, and I have to preface myself, in 1990 through 92, I was one of the few persons who was in Rwanda during the war. In fact, I brought U.S. aid to Rwanda because people were eating my seeds, and one day that I came, I saw 56,000 people with no clothes on, eating seeds in 25-degree weather in the mountains. And I remember telling the U.S. ambassador when I got back, I can't celebrate with you all while I have people that are eating and no shelter in the cold. And what they said to me was, Mr. Backus, let me just say one thing to you, because I would go through 15 to 20 barriers a day. And this is very important for me as to why I'm in this work, is that they took me for either Hutu or Tutsi for every step that I make, but my little raggedy trucks made it on up to see that they were okay. And one day, one gentleman said to me, he said, you need to understand one thing. We don't expect that you will take care of all of this, but here's the way it goes. We know that we will either die from the war with a fast death, or we'll either die from AIDS. But the fact that you keep coming up and so many people left us, you bring us hope. And they had a certain faith about them. I must say that the spiritual and faith community within the Black community is very, very powerful source. That's why the church is so critical with what we do and where we work. So the biggest thing is public awareness. One of the things that we found is that when you write literature of all types, it has to be in a vernacular that people can understand it. So a lot of what we do in church work or wherever we are, we talk at the level and listen to what people are saying to us and don't make any assumptions. So we begin to develop educational materials and websites that become very, very key. And there we will see the reaction of the people. They are interested in what do I do when I start my prostate cancer journey? How do I even understand what a prostate is? So we've developed our own website tools. We have FIN PSA. If you look at that website, it deals with early detection. And all of the pieces, even in telling you the size of the prostate and all of these pieces. Then we look at the issue of what has happened with trials over the history of Blacks in America. And in doing that, we've developed our clinical trials site. We even look at all the sites and that are there from the government with clinical trials. If you look at that, we go through each trial, rewrite that in a language that people can understand. We help build the trust. We listen and we build the trust in that community because it's been bereft of those types of supports in the past. You can't move a person if they don't trust you. I will tell you that from what I saw in Rwanda. We moved it so that people got help and the U.S. government moved in to make things happen. That's what we're looking at. We not only have fintrials.com, but we have FinPSA, FinTrials, I got to remember, FinPath. On the issue of treatments, that's very critical because a lot of metastasized issues with people come late. They get late treatments, and that's one of the issues when we're talking about 120% rate in terms of death. That's something I didn't even hear overseas. That 70-something% incidence rate, that's something that's not tolerable in America, in my view, from what I've seen in my life in places that I've worked. So, as I said, we build these websites, so clinical trials, PSA, FinPath for treatments, and then we now doing finchurch.org. that we're doing. So I just want to make sure I don't miss them all. So PATH, church, trials, PSA, all of that is educational information. And when I talk a little later about the rallies that we are doing, yes, we've gone into 23 cities. I was told, you can try this radio, it's not going to work. Radio is one of the most critical means when people are driving or whatever that they listen. What do we find out of 23 cities? 23 cities and 14 states, and headed tomorrow morning at 5 o'clock to Mississippi. We found that people come to the website. We are using these educational tools and information and website to put it out there free of charge for everybody to look at. When we finish doing a radio campaign, social media campaign, we will see on the listing of states which states come to the top based on coming to our website to pull this information off, this educational information. And in every case, out of every 23 cities that we've been in, and states, those states and cities come to the top, 1, 2, or 3. We've reached, at this point, over 20 million people. We focus, if you look at the map, we focus on where the 37 million people are. Mr. Farrington is very critical about research. We even make sure that you're saying prostate and not prostrate. I'm serious. I tell people you don't want them to cut the wrong thing here, bro. Let's just be clear. We make sure if you're talking Viagra, it ain't Viagra. You don't want to get the wrong thing. It's informational. It's too critical. It's a death sentence. That's the way we look at it. But we bring hope. So I don't want to say too much. I'll get too happy up here and I might have church. But thank you. Thank you. I think it's important. Sorry.
I'm from Atlanta. I'll sit in your pew all the time. So, Shanta, one of the things that you spoke about was sort of these social determinants of health, right? So it's real great to talk about blood tests, but for some people, that blood test is like the 50th thing on their list of things that they worry about. So in the work that you see and in your experience, how are you all addressing the challenges to this very sort of local need and communication around screening and health when in fact that might be the least of the thing on someone's mind?
So I was sitting here and I'm listening and I said, everything we're talking about is based upon one being connected to the healthcare system. What about all of those people who are not? Most people, I'm not stereotyping men. I was married for 25 years, so, you all have an episodic relationship with the healthcare system.
Episodic. At best.
At best. Sometimes twice on weekends, right? And so, like I said before, we're making the assumption that health takes place in the four walls of the healthcare delivery system, and it does not. And we have to really begin to go upstream and ask ourselves, what are those critical factors, right? And so, as I've touched on, we've had this partnership with Zero for some time around this Zero 360, and I wanted to pull these numbers up because I think it's very important, again, as you prepare for tomorrow. So we, again, address these non-clinical barriers to care, so all of these administrative and financial barriers to care. And so for the men that we serve at PAF, the number one issue that they raised was around copay assistance, financial medical bill, and Medicare Part D sharing. It's followed by the second barrier was transportation, financial cost of living, and gas assistance. Third was coinsurance. There's a difference between deductible and coinsurance. And the fourth one, I'm just giving you the top four, was housing and financial cost of living and rental assistance. So if these are the top four issues that men are saying that they are encountering when trying to access care, nowhere at the top of that was that care. It is, this is why I don't, or this is why I can't. Because if there is something found, do I have the resources to be able to be treated? If not, am I robbing Peter to pay Paul? And in many households, Peter and Paul have been robbed so much that they left. So it's the reality of these things. And then you're asking me now to go for this appointment. Then if you find something at this appointment, I have to come back and go to another appointment. Did you forget that I work a 9-to-5 job? I'm hourly, maybe a labor union, maybe not. So I'm having to take time off of work to go to these appointments. So I'm losing money, but I'm incurring expenses. And so these are the realities. And so now, okay, now I'm going to go and you want me to have a conversation, you want me to have this informed conversation with my healthcare provider, but as soon as I walk in a room, he or she has already created this image of who I am as an individual. But you want me to trust you. You want me to trust that you have my best interest in heart. So these are not things that we went out and made up. These were the things that the patients that came to us were saying, help me mitigate these barriers. But oftentimes our society has not been designed in a way where we say to men, hey, we're going to help you find the financial resources for that therapy or financial resources to help with that housing or transportation, all these things. We just started doing this for women a few years ago, if we be honest. And so oftentimes our men are not coming into care because this is what's on top of their mind, the what if. Yes, we want our men to be screened, but we also want them to know that there's a safety net system called our health ecosystem that is also around to support them so that we're addressing these barriers which are very real. Cost of living, transportation, housing, copay assistance, and the time off work. And this is for men who are insured. When we start talking about men who are uninsured, just amplify everything I've told you 10 times. So as we think about our path forward, we have to think about it in a way that we create a social structure that addresses these existing dynamics. So not only can men access care, but they can actually adhere to care.
And I think you make a great point around, insured versus uninsured. If we were to put up the map of where the greatest disparities are, first of all, they're not disparities in healthcare just in prostate cancer. They're usually across the entire gamut, but they also often fall in line with socioeconomic status. They fall in line with sometimes education levels. They fall in line with whether or not Medicaid has been expanded in that state and insurance rates. So prostate cancer does not live by itself in a vacuum in what we're doing. So let me ask you this, and I'll start with you, Shanta, and I might get taken to church here again, so I'm ready, is what can this group of people in this room do when we are fighting the battle on all fronts? Not just cost, stigma, but there's all of this going around. What do these people do to help?
Jesus.
How much time?
And I will say that I might have stepped in it because that was not on my pre-approved list of questions to ask.
I think I said it in my opening comments. We got to stop falling for the talking points and really hold everyone accountable, the entire health ecosystem, from pharma through policy. Everybody has to be held accountable in this. There was an article last year that was entitled, "Without health insurance, poverty is just a medical bill away," right?
People need to hear a cohesive and coherent message. And sometimes where I get concerned in our nation is that sometimes our messages are so bifurcated. It's not a time for that. It's a time to really come together if we focus on the aspect of humanity and health. And this is a critical one. We need every male. When I look at my grandsons, when I think about the next generation of people or the next generation of leaders, it's not just us sitting here, but what about your children and children sitting here and hearing those voices as well for that generation that you are trying to prepare for? That's what we're not doing across the board in a lot of issues in our nation. In this one, let's do that because it's an issue of humanity. And for me, it doesn't separate, it stays together.
I love that. So, now I'm going to turn to our doctors. What do you feel that the medical community should be doing that they're not?
Well, first of all, you know, cancer is not a partisan issue. I think I'm going to reflect a little bit just what we heard here. And, you know, we talked a lot earlier about cancer screening, but to get a blood test where you can't have follow-up based on that is a waste of everybody's time. And so when we think about screening, it really has to be through the full continuum on to treatment. Otherwise, we're sort of kidding ourselves. And so, you know, you may have heard it's an election year, and we still don't have an NIH budget, and we don't have other aspects, PSA for Him bill, other things that are out there. So there's real stuff in your communities that I think people need to hear your voices on cancer issues, you know, nonpartisan issues. So I think that's sort of following up on here. So, and then we also, as the medical community, need to make sure we have care where the patients are. You know, we have folks at cancer centers, you know, like Chuck, with their spectacular care, but most patients don't receive their care in the cancer center. So what can we do to increase equity, make sure there's actually excellent care throughout the country to ensure that your lifespan is not determined by your zip code. So we need to find ways to increase, you know, evidence-based care, access to care everywhere, and some of that may be technology-based, but if we do that, we don't want that just to increase disparities. So I think, you know, ensuring that there's education, training, outreach, but then again that there's advocacy supporting the resources needed to do that, whether it's NIH budget, PSA Him bill, or whatever is needed. So the full continuum of care is not simply on screening. So
I'll just make two comments. Yeah. So one is, I think if I could somehow wave a magic wand and have every man between the age of 41 and 50 have a mandated doctor visit at some point during the decade, we could save a lot of lives. And I'm not just talking about prostate cancer. I mean, you know, screening, we're talking about prostate cancer, obviously, but screening and a touch point with the healthcare system in that moment will help identify a number of chronic diseases, including the #1 killer of men, which is heart disease. And so I think that that's something that the medical community should embrace as trying to package that in a way that it actually happens, somehow incentivizing men, either through employers, insurers, et cetera, to go in and have a touch point with healthcare in their 40s. That's #1. #2 is, I always, whenever I'm in an opportunity like this, I would like to say, of course, you are the advocates who have already voted with your feet by coming here, and so you're already the champions. But one of the things that I have always encouraged people to do is to share their stories, which I'm sure many of you are doing, share their family history, because I've been in medical practice for a long time, and part of doing a workup of a patient is to understand their family history. And it's surprising how much, when you're sitting with a man with prostate cancer, for example, and you ask, any other cases of prostate cancer in your family? They will say, well, Dad had something in his bones, but we don't know what it was. Or so-and-so had this and that. And really, that's just something that could happen around a holiday dinner table, or it could happen via email or something where people just disclose a little bit of their family history, because in doing so, it can save lives of family members. There are cancers that are detected earlier because of family history. There are genes that drive cancers in family members, and now there are even therapies that are specifically related and tailored to some of the genetic mutations that are driven by family history. So know your family history and tell your loved ones to know their family history and to spread it.
That's a great point. I first was touched by cancer when at 21 years old, my 23-year-old brother was diagnosed with colorectal cancer. And then I was diagnosed with breast cancer, only 8 years later. And when we were trying to talk about our family history, all I heard was, well, your grandmother had some sort of girl cancer. I was like, really? I mean, there's a lot we could choose from here. We don't know. And because we didn't talk about it, right? And so I think that removing the shame and the stigma of sharing that information, it wasn't that long ago that people just referred to it as the big C, right? And a lot has changed in that respect, but prostate cancer is a little bit further behind. And it was only through that investigation that I actually realized that my uncle had prostate cancer when he was 50, and he had melanoma when he was 26. And FYI, they're kind of connected. So it's certainly something that comes into play. So let me ask you all,
Courtney,
go for it,
can
Shanta.
Can I just add something? I think it's also important we've kind of pigeonholed how we have these conversations in families around cancer, meaning that, let's say, my godbrother was just diagnosed with prostate cancer, right? His mother had breast cancer. But there's this assumption that just because he's a son, that we're not having these conversations about cancer across the whole entire family bloodline. So I think we have to be careful and say that these are still conversations we need to have as collective, because we've kind of said, okay, if it's a woman and she has no female children, then we don't need to have these cancer conversations. So I think we need to broaden the family conversation about cancer.
That is totally true. I have a son, and because of my family history and obviously a lot of cancer in my family, we have those conversations very early. Probably too much if you were to ask my almost 15-year-old son, who just recently was stuck in a car with me, and I said, so let's talk. Do you know your prostate? Oh, God, Mom.
A short conversation.
We were trapped in the car for an hour. There was nowhere he could run. So that's what happens when Mom works in healthcare. So as we sort of think about, translating in tomorrow, and you could empower this group to do one thing that we have not talked about that could help remove disparities in their own community. So being up on the Hill is great, but then they got to go back home. And if they could do one thing in their community to remove disparities, what would it be?
I would get people involved in clinical trials. We've looked at the data over the last 30 years. The percentage of black men involved in prostate cancer clinical trials has not changed. And we know about 20% of the men with advanced disease are black men, and the percentage of black men on clinical trials is under 5% generally, depending on the trial. So understanding that on a clinical trial, by and large, patients, first of all, there's not placebo groups for men with advanced cancer. Everybody's getting an active therapy. They should be getting at least a standard of care. And there's often access to new treatments. There's better follow-up. The outcomes are very good. So to sort of get over that hurdle, understanding. Now, I don't want to blame the patients here. A lot of times it's on the system. If we look at race-based data, if you had a white person or a black person to be enrolled on trials, the answers are the same by and large for each group. So we need to have increased access to the trials. We need to have trials in the community. We need to have the kind of trials that people can do who can't fly off 3 days of work for PK work. But I think having that increased trial, increased expertise in the community could do potentially significant amounts to change outcomes. So that's just one thing I would encourage.
Chuck's like chomping at the bit here to.
Well, I was going to say clinical trials, but now that you said it, I'll do you one better, which is actually, I think, we were talking about this earlier. Every one of you most likely lives within 100, 150 miles of an NCI-designated comprehensive cancer center. All of those cancer centers get their money from your taxpayer dollars to promote cancer research, good cancer care, and they have a mandate to serve their community, which is where you live. And all of them have what's called a community outreach and engagement component to being the cancer center. And all of them want to have an army of people who are out there in the community helping them to spread the word of whatever cancer center it is. So one thing you could do is you could find out what is the cancer center in your area. I live in Minneapolis, where the University of Minnesota Comprehensive Cancer Center is right down the street from me. And we have a significant group of people working on community outreach and engagement. And you could contact them and say, what can I do to help the cancer center here to do this mission better in my area? That can in turn lead to improved scoring from the National Cancer Institute, improved funding, and improvements in outcome to people in your area.
I think for me, and I'm going to do a cutting edge kind of thing.
Go for it.
Is there a back door?
We'll make one for you.
Let's envision something different. And I probably haven't even said this in my organization. It's unfortunate for all the many years that have studied this and studied that in law and all this, we still have not overcome the 11th hour on Sunday, separation in this country, in my view. A lot of churches, like one we work with, Enon, one of our partners in the spring, they have a thing called Know Your Numbers. We've been working in education with all these churches, and they screen a total of about 600 men. They found them from the cities, they bring them, veterans, everybody in. Another church in Virginia we work with, First Baptist Church of South Richmond. This year, for the first time, we did an educational component with them. They had 57 men who came to the education, but those 57 men got screened. But what will happen if we look at white and black and whomever, and you communicate through these churches and say, we want to do a big PSA screening program or project with you? It's not enough shared responsibility, if I want to say, to lift this thing up higher. Sure, we can do it, and we should do it in our community, but when have we ever thought about it as an issue? If one is suffering and things can happen like the tools we develop for fin trials and fin to get people, don't you know that benefits every other group that's there? Can we bring it higher? That's something that's always been an issue for me growing up in the segregated South in North Carolina. I left there and went to Chapel Hill, and people said, you can't do and can't do, and some said you can do, and I ended up in France. I left there and I ended up in Paris. I ended up because someone provided an opportunity for me, and it wasn't just black, and it wasn't just white. It's because they dare venture to agree with, this is an issue that we can invest in you as a human being because we see something in you. I want people to begin to see something in each other. We are getting blinded. I'm very serious about this. See if your church can reach over and say, what is your church doing with PSA? You know, I have some people say, well, you talk to your community because I can't do it as a white man. And I'm saying, no, you can do it as a human being. And you might bring a resource that we don't have. You might open the eyes in your community to say, we see that here in Mississippi. We see that in North Carolina. We see these statistics. What can we do about it? That's the thing that I would say reaches a little further than where we are. I'm not asking for a dime. It's just asking for support. Like the person said, your presence brings hope. Don't underestimate who you are and what you bring to the table. I would challenge everybody for that. Same with in our community. What are you doing in yours? We just have this habit of saying, take care of yours and you take care of yours. But yet we got these statistics in America. There's something wrong with that. So I'm glad I'm here. I'm glad with organizations. But sometimes we don't say that enough. Let's hold hands and do the things together that save all of our lives. Not just some of ours, all of our lives. I've had enough. It's a shame that people have to stay in their houses worried about what's going to happen tomorrow. From politics to economics to religion, your children, they're confused. My children are confused. We need to stop in America right now. So I'm saying that means we have to put everything aside and say, I see you, ma'am, as a human being, because there's something that you're bringing to me. When I worked with the church, I saw poor in Maine. I saw poor in New York. And I came up because they had resources and said, Adrian, can you help us? And for the first time, they said, wow, you're helping us here. And I said to myself, wow, I'm with all of these white folks, and they're loving me. And then the lady looked at me when we all in tears. She said, Adrian, just want to understand one thing now. It's only you. But there's truth to that. But what was right is that you have something we need, and we have something that you need, and that's love. Amen. So don't go to church and preach about love if you can't show it in some way. Take the risk to do it. I mean it. I'm sorry.
Adrian must have gotten my memo that I said last night that we just weren't pissed off enough.
And the church said, amen. So I know you said one, but I have three. The very first one is, in the session before us, they pointed out that we still have states that have not expanded Medicaid. So when you go back, if you happen to be in one of those states, ignite those conversations. That's something you can do when you leave. Secondly, let's start some different conversations around pipeline. We've all seen the narrative, especially as it relates to black males, that if by 3rd grade that they can't read, then they're on this pipeline path to prison. Why can't we have them on a pipeline path to becoming the next series of oncologists and health professionals? Why do we have to accept that as being the narrative? Let's write a new narrative about what 3rd grade means in terms of starting these pipelines into health careers. And thirdly, again, I would say, tell the story of your community. No one, not the story that's around just your table, but tell the story of your neighbor's table. Because we've all been in some rooms and we've seen who has been missing from the table. So it is our time to extend an olive branch and say, hey, this person needs to be at the table. And if there isn't a seat, bring a seat with you. Because that is the only way the voices that have been muted, notice I didn't say silence, but the voices that have been muted for so long, they won't be in these echo chambers if we don't create a space at the table for them. And more importantly, bring them to the table with us. One of the things that you pointed out, I think, is critical is we forgot about the promise of humanity in this country. And now is a time for us to return back to what that means. It's going to mean different things. We've allowed people to polarize things as being black and white. And it's not about black and white, it's really about blood. Because if you cut any of us in this room, we're gonna all bleed some red blood. And so it's our collective passion for this work, our collective intellect for this work, and our collective commitment for this that is really going to turn the tide. So as you leave tomorrow, go back, sit in your local legislative offices, sit in your state legislative offices, and as Reverend Adrian said, enough of this is enough. And as we pointed out, whether it's a designated cancer center or a local nonprofit hospital, each of them is accountable to you as a constituent in the community. If there is a patient advisory board, raise your hand, sign up, be present. Don't fall for the okie doke. Every single nonprofit hospital has to do a community needs assessment, not a hospital need assessment. It's a community needs assessment. Don't let them just complete these activities in silo and what your community need not be reflected. If they put it on paper, make them accountable for acting on it. We have to stop not holding people accountable. Right. And that accountability starts with us.
That's true. And to what you said, Shanta, about inviting people to the table, I would also say a really great mentor for me in Atlanta once said, it's not enough that they have a seat at the table. They have to feel welcomed at the table. It's not enough that they're welcomed at the table if they can't read the menu. And why should they just read the menu? Why weren't they to part in writing it? And so here at Zero, we know that when it comes to health equity, it also involves making sure that our own house is in order. So we've been doing some things internally to make sure that we are better prepared as an organization to do that. And that's involved working with some people that have really been helping us. And what they tell us all the time is that allyship is a verb. Being an ally is a verb. And that's something that we think of all the time as we're doing this work, because there's no way we're going to be able to do it alone. So with that, Allie, I think, is giving me a sign that we have a couple of minutes for a couple of questions. So does anybody have a question? I see a hand right there in the back. I don't know if we have a microphone for her or if she's just, you know. Oh, even better. I don't need to talk anymore. I'm done.
Thank you. I just want to say that we started out this morning with saying, from Courtney, we're here to change the world. And from what I've heard today, and I just want to thank God for Courtney for being that person who is sick and tired and want to make a loud noise. Well, I'm taking this back to Ahoskie, North Carolina, which is one of the counties that has the highest death rates of prostate cancer. And this did not just happen. My father died, Courtney mentioned 20 years, okay? My father died 28 years ago. He left a little town to go to the VA in Delaware. They transferred him to Philadelphia. He found out there he had metastatic prostate cancer. So it's more, you get the disparities, you get, you know, the deserts, and now the new word that was just mentioned, pipeline, I think is what you said. But it's more than that. I can't tell you how much women try to get men to the doctor, and then you're called on. And then my father didn't raise me, so I was called from Philadelphia that I had to take care of my father. And I'm here to tell you, I just lost a husband in March, last November 22. I lost my mother in March, it'll be a year. And then I got, all of a sudden, October, I go in for my annual checkup, and they see something on my left breast. So my phone is ringing off the hook because the doctors are trying to find me. But I'm here to tell you, I'm not giving up. We need you, Zero, to come to that area. We do, every year, we have a evening in blue. We cannot find any churches in the area. We can't find any organizations because they think we're in competition. This is not a competition. This is real. And what I'm trying to say to you is that I heard everything you said, and I'm still going to live no matter what. They found it, they took it out. The doctor was trying to reach me to tell me, we got it all, but we have to follow the protocol. So I don't want to follow the protocol. I don't want to do the chemo. I don't want to do the radiation. I want to know what's out here. And the only way we're going to find that out is if all of us, it's not about the walks. It's not about any of that. All of us, and yes, I am angry right now because we didn't have to get to this point, but we are. And I need you in this small area. It's dying of North Carolina.
Let me tell you, you got us. You got us. There's a reason why this partnership is existing, and this is the way my God works. I have to use my faith here. I'm from Edenton, North Carolina, which is about 30 miles or so from Ahoskie. And I want to tell you this story because you got us. Last year, we were in Raleigh with these, this is the power of these disparity rallies, of bringing medical professionals, churches, and other leaders, community leaders together, and then having a town hall meeting. We're with Duke and with the University of North Carolina. All of them were present. When I did my church rally in Raleigh, they were present, and we did the whole piece. Now the University of North Carolina, which is my alma mater, their urology department, is going around with Phil Ford, some of our people, and others, and trying to hit Eastern North Carolina. They just had a rally at one of the churches in New Bern. They had one, I think, in Goldsboro, and I got to make sure now they come to a Hosky. Because this is the power of these types of meetings, is that you never know who you're running into and where you're from. And it doesn't matter, like I said, the University of North Carolina, they got buses. The other thing is we work also, some of our church, with LabCorp and others who can do the PSAs. But if there's no church, I know what you mean by not signing up, but there's a program that is going around and information is being disseminated about the disparity in North Carolina. There was even a discussion about a bus. They wanted to buy a mobile unit because I know what you're saying. In Edenton, some of our people have to go all the way up to Durham or Duke or go all the way into Virginia. And some of those statistics are very heavy in every state we go through. What I'm seeing in Mississippi is very interesting, but every state we go through, regionally, they're bereft from services. So all of our services, all of our programs have to connect because it makes the connection like you're saying. And hopefully it will change your life and provide you life. And anybody else in here, but thank you, I didn't mean to sound so loud.
First, I'd like to share the 0360 program that we talked about. So, once you get to the screening part and those other barriers start to raise up, that 0360 is available. That number is 844-244-1306. Anybody who is sitting in this room, if the person has access to a telephone, they can access this 0360 program and all the case management support that I mentioned earlier. So this is a part of this partnership with PAF and Zero to really bring tangible resources into the homes and communities of individuals to address these non-clinical barriers to care.
Okay, hi, thank you so much for this conversation. I lost my father November 27th of last year to prostate cancer, and I just really appreciate this community and everything that you've shared. In 2016, my daughter was born in 2016, and when I went to her pediatrician, I asked her about different tests that I might be able to give her, and her pediatrician said to me, "You are her biggest advocate." So we are our first advocates in our own health. But one of the things that I'm hearing in terms of Black men is that the research is off. It hasn't been enough research. There's not enough data for Black men. I'm also hearing, that there's a lot on the patient to find out information, which it's part of their responsibility. But if there isn't enough research on Black men, and we heard earlier from Morehouse, I forgot your name, I'm sorry. She mentioned a tumor or cell that she'd found that had been found in white men, but not tested in Black men, if I'm correct. So what conversation or what education is being given to doctors, white, Black, other, to have these effective communications that we keep telling our patients to have? What kind of education is given to these doctors on Black men with prostate cancer to support their care? Because I can tell you, when my father was going to his doctors, the conversations were very basic, not enough information. I have information now, but it doesn't do my father any good. I hope that I can bring awareness to other men, but in terms of doctors, you only have that short period of time. What information is that doctor coming into the room with about Black men?
So I can address this a little bit. So first of all, the regulator of your doctor's information is unfortunately your doctor. And he or she, they have to decide how much they want to be self-educated around changes in the field. And that's actually, I'm embarrassed to say as a physician myself, it's a bit of a problem. There are people who just aren't curious enough about a new condition or a condition that they only see rarely, where they are out and studying it and thinking about it ahead of time. However, having said that, doctors have never before had so many resources available to them to educate themselves about changes and various different aspects of prostate cancer or any other health condition. And I would say that, that this issue of disparities in outcomes is, for a whole host of reasons we all know, is at the top of mind in the country. In every medical school, every cancer center, and every, I think, granting society as well. So it's very much a topic that is being discussed, and there is a lot of money pouring into looking at research in, for example, black men with prostate cancer, and what is the root of the disparity. And I will tell you a couple things. One is there have been really interesting observations that have been found, for example, that when you correct for the system, right, and you look at the VA system, for example, where the system is uniform, whether you're in Wilmington, Delaware, or San Diego, California, and when you correct for the system, black men have equal outcomes to white men in the VA system compared to when looking at, for example, a Medicare population or private insurer population. So that's interesting, right? It says that there's a system issue here. But there's a lot of work going on to show that there's actually differences in the disease, and depending on the population. And it's not so much to say that there is a form of prostate cancer for black men and a form of prostate cancer for white men. It's just that there are variances across all populations, and some of them have different higher prevalence in different populations. And so there's a lot of potential for biological differences to be determined, and that research is underway from a variety of different funding avenues: Prostate Cancer Foundation, Department of Defense, National Institutes of Health, and even the pharma industry is now diving into that and looking at differences in outcome.
One of the things that I've found, which is very interesting to me, I'm learning a lot with this. I think it's very key that you learn as you work, is that there are very few black urologists. In fact, what is so exciting to me about Mississippi is that one of the hospitals down there have 2 black urologists. And these men are working all day. We could barely get their photos because they're in and out, in and out, in and out. I have another dear friend that I was studied in France with who had a nice practice in Savannah, and he was there, and he joined us in these rallies, and he said, I never knew all of this was happening. And he'd been practicing for about 30 years. And so one of the things, I think that's where our tools are very helpful, because what we found is that when many of the people read either the FIN PSA or FIN trials, they get information that empower them to ask questions. And what I'm recognizing is that when they ask these questions to their primary care physicians, we've been told by some that they've walked out of the room, because sometimes it's a bit intimidating. They may not be as focused on prostate cancer as they would in other aspects of their practices. So one of the things is empowering oneself as much as you can. That's why we believe with knowledge and providing the information so you can really advocate, self-advocate aspects of your journey. But the question is, will it be received when you have options about your life? That's what I'm seeing. Let me say that much. So this issue between primary care physicians and the issue of urologists, in fact, in every town hall meeting, there's a big different discussion going on. Am I right, Doc?
You're very right.
And that's something, too, that might be part of, this is what I'm learning as I go around to all these cities and states and sit in meetings like these. That's a real critical fact. So preparing young black urologists at HBCUs aware, to me, is critical. I think, from what I'm understanding, I could be wrong, you can enhance that.
No, and I would just say, I don't need a microphone, right? Probably enough. Remember when I said that doctor who said empowered patients make better doctors? This guy, right here. So we can go back and speak to our friends, our families, our fellow advocates, because the more we're armed, we hold them accountable. And so the idea that you would go to a doctor and not ask questions and not push, that is one thing we can learn from our pink ribbon friends, is we must hold our doctors accountable for the decisions and the options they're giving us. If they have a hammer, everything is a nail. So you must ask them if what they're giving you as options, is that what they're giving you because it's best for you, or if it's what is offered at their facility? Because those answers are different.
Yeah.
Or if they're offering it based upon what they think you can afford.
That is true. All right. I think that's a good one right there.